Hello, guys.
James. So
Hey. Let's go. That. Okay. And here. And see what else we got shaking. They have two. Perfect, have two. All right, so let's shoot this out. There we go. Okay. Resend. There we go. This is 2-4. Okay. Put this up. And here. Here. There we go. There we are. And there we go. Really? Wow. Okay. We got trouble. So let's try again.
The construction.
Okay. That one. Okay. Good. All right. Okay. Now it's good. All right. That. And that. And share. Go to here. Use the share. And then do a new share. Go into here. New share. And there we go. All right. Now let's see what else here. Chat. Participants. Good. Okay. All right. Looks like we're all basically here. Okay. I emailed the notes to you just now, so they should pop up momentarily, but I also posted in the chat so that you can download. All right. And today The topic is GI disorders and renal disorders. Now, one of the questions I'm sure you've all got is about the exam scores, and I haven't posted those yet because everybody hadn't taken it yet. Okay, so I'm waiting for a couple of scores to come in, and then I'll post. Okay, so just hold on for that to happen, and then we'll be all set. All right. Now, last week we talked about the digestive system's anatomy and physiology, basically the trip that food takes from the oral cavity to the anus and all the different things that happen along the way. And we talked a little bit about some of the problems that can happen in the digestive system, such as GERD or appendicitis or diverticulosis or Crohn's disease. Okay. We're going to go into a little bit more detail today about some of these different conditions and the appropriate treatments. Okay. So let me go. All right. So we're going to talk about all the conditions listed here. Okay. We'll go into each one of them. We'll talk about what's happening in each scenario, right? Each condition. And then we'll talk about how we alter the diet in order to deal with it. Okay. So to understand it first, we have to talk about what's wrong, what isn't working, and then we have to make sense of how we would change the patient's diet to approach each of these different conditions. Okay. So let's start with nausea and vomiting. Now, this is something that we've all experienced at some point in our life, I'm sure. Okay. What is it? Why does it happen? Well, it happens because there's something, generally it happens because there's something inside the, the digestive tract that is an irritant. Okay. This could be a pathogen or a toxin. Okay. Other causes for this would include things like emotional states, okay, or conditions like motion sickness. All right. Um, with this kind of stuff, as a result of an emotional state or motion sickness, the way to deal with it in the case of motion sickness is to stop the movement. Okay. I don't know if any of you have ever been motion sick or seasick, but generally, as soon as the movement is over, then the condition goes away. All right. And it has to do with essentially the a problem with your eyes and your inner ear disagreeing with what they're picking up. Okay. Your inner ear can't anticipate what your eyes are seeing. And the fact that that information is conflicting in your brain causes nausea in your GI, and that's why you experience those symptoms. Okay. And when the movement stops, the condition stops. If it's due to an emotional state, all right, like stress or anxiety, then when we relieve the stress or anxiety, the pain will go away. Okay. The other condition in which this happens, it's not related to a GI problem, is extreme pain. Okay. For instance, the pain of the kidney stone can cause nausea and vomiting. Okay. And in that case, what we have to do is treat the pain, and generally that condition will go away. So the idea behind nausea and vomiting when it's not caused by an irritant, okay, is to treat the underlying condition, and then everything should be back the way it was before. But if there is a problem in the GI, if there is a toxin or a pathogen in the GI, then we have to consider that this is actually something that your body is trying to do to clear it. Okay. So the idea here is that there's something in there that's an irritant, and the reason you're throwing up is to get rid of the irritant that's causing the problem. Okay. Potential causes listed here, right? Decreased gastric acid secretion, decreased GI motility, meaning the material's not moving through the tract quickly enough. Allergies to foods, okay? Bacterial or viral infection, increased intracranial pressure. Okay, now that's something that's neurological, all right, and that's going to be treated when we deal with the problem of the intracranial pressure. okay? Liver, pancreatic, and gallbladder disorders, and adverse effects of certain medications, okay? With the exception of the intracranial pressure, all of these are causing irritation and inflammation in the digestive system. And the idea behind the nausea and the vomiting, which clinically is called emesis, is to clear that out, okay? So we try to find the underlying cause, all right? Um, Appearance of the emesis will help in trying to determine what's wrong, right? And such as coffee ground emesis indicates the presence of blood, and pale green indicates bile, right? Now you might wonder um, why it looks like coffee grounds if it's blood in the emesis, and the answer is that when the acid in the stomach reacts with the blood, it turns it into a black particulate. Okay, looks like coffee grounds, right? The bile is just something again that's um, ending up where it shouldn't be. Okay, it's ending up in the esophagus and in the oral cavity, and it's not supposed to be there, right? The bile is supposed to be confined in the digestive system to the liver, the gallbladder, and the small intestine. Okay, so if there's bile in your emesis, then we have severe irritation. Once the symptoms subside, start with clear liquids followed by a full liquid diet, and then advance the diet as can be tolerated, right? So we start slow. We start with something that won't cause a lot of work for the digestive system, and then we work up from there. You want easy to digest, low fat carbohydrate foods such as crackers, toast, oatmeal, pretzels, bread, and fruit that are usually well tolerated. You go slow, you take a little bite, you see if you can keep it down, and then if you can, you continue. Okay. Class, you stop liquids with meals because they promote fullness. You want good oral hygiene with toothbrushing, mouth swabs, mouthwash, and ice chips. Now, why is this? Because the acid in the emesis is going to erode, well, not only the oral cavity and the esophagus, but it's also going to erode the enamel on your teeth, right? So you want to make sure and clear that out so that you don't promote things like dental cavities, right? This is one of the same problems that people that undergo bulimia experience when they try to induce vomiting themselves, right? Is that they erode their esophagus and their oral cavity and the enamel on their teeth, okay? Raise the head of the bed. Now, why is this? This is to try and keep the stuff down that we want to keep down, okay? It's also to make sure that we don't have emesis and the patient ends up choking on their own emesis, right? If they're lying down and they're weak, it's possible that they could throw up and then choke on that, right? You want to discourage hot and spicy foods because they're going to promote more irritation as they come back up. And you want to serve foods at room temperature or chilled. Avoid high fat because they contribute to nausea. If they contribute to nausea because they're tougher to digest, fats take longer in the digestive system. Okay. So this is just your body's way of saying, I want it out. Okay. And once it's out, then we should be good to go slowly, step by step. Okay. All right. This is a look at anorexia.
I think that anorexia is a death wish. Really, it's suicide, and I felt like it was the most natural suicide possible. I was in the like angst of teenage, like hell, thinking everything was awful and I needed to die, and it felt powerful because I think like your junior year of high school, you're really busy, and I had that extra hour during lunch when everyone would be sitting around eating. I could go and do more work because I didn't have to eat because I was so much better than everyone else. I think the final moment when I decided, okay, I need help, was they were going to hospitalize me because I wasn't eating at all, and I had dropped. I mean, I'm 5'7" and I'm medium boned, and I dropped from like 117 pounds to like 98, I think, in a couple of weeks. And I sing. I'm studying singing, and the doctor was telling me, what do you think your vocal? What do you think makes you sing? And it's muscle, and your body has no fat, and it's eating your muscle now. And the most important thing to me in the world was singing. So I was like, oh God, I can't do this. I can't destroy what I love the most. And so then I realized I have to get help for this. I don't think that I need to lose weight anymore. I've come a long way. I'd rather put on weight, but I do have days. It's such a power thing. It really is a power thing where if I'm stressed, where there's a family stress or anything, not eating makes me feel powerful. If somebody had told me when I was like all the way back in the beginning of all this, that if I lost weight and gained weight, lost weight and gained weight, I was going to get, horrible stretch marks, that I was going to lose all my hair because it was just going to fall out, that my skin was going to get dry and gross, that my eyes were going to like go back into their sockets. I'd have constant dark circles that no concealer could cover up. If someone had told me how ugly I looked being that thin, I wouldn't have done it. I mean, it was part beauty and part power, but it's just like when I put on weight, I'm healthy, I look better, everything works better, I can concentrate in class, I don't lose my concentration. I mean, there were days when I would be so weak that I couldn't get out of bed to go to school. And it's not worth it.
So what you're looking at here in anorexia is a body image condition, psychological disorder in which the individual feels that they're overweight even when they're underweight or normal weight. And so they deliberately forego eating. The result of that is that the body is going to begin to digest its own protein in an effort to keep you alive. It's similar to what happens in conditions like kwashiorkor or marasmus, where the diet in these individuals, this is usually a third world country disease, is so lacking in protein that the body starts to digest its own protein. And when that happens, you lose muscle mass, you lose connective tissue, you're going to lose blood pressure and blood volume because you can't make blood proteins like albumin, and you're going to start to lose blood volume to other compartments in the body, like the abdominal pelvic cavity, and that's why the abdomen in marasmus and kwashiorkor will distend, right, as it collects fluid. Okay, you'll become weak, right? You'll become more prone to disease. All of the things that you need protein for are going to start to break down, and eventually, if you keep this up, you're going to die. Okay, there's no way around it. So again, with anorexia, what you need to do is to treat the underlying condition, right? And so this comes with counseling, therapy, all right? And then you're able to re-engage with nutrition, all right? So how do we deal with this? You want to decrease stress at mealtime, collect data about adverse effects of medication so that we know what to change, what to add as far as meds go. Give medications to stimulate the appetite. There's a variety of those. Modify the environment for unpleasant odors, unpleasant lighting, unpleasant atmosphere. Okay, you want to make everything as appetizing as possible. Remove items that cause loss of appetite. This could be any of a number of things. I mean, there's some obvious ones listed here, but sometimes patients prefer a certain temperature in the room, a certain atmosphere in the room, right? Maybe some music. You don't know, right? You have to ask the patient what they like. Okay. Assess and manage anxiety and depression. Give small and frequent meals and stop high fat foods, again, because they take longer to digest. Okay. Maximize intake. Give liquid supplements between meals to improve protein intake and calorie intake. Make sure that meals are appealing. Serve big meals early in the day. Look for changes in bowel status, such as gastric emptying, constipation, and diarrhea. Now, why might this happen? Well, if the individual has been eating for a while, okay, the stomach will shrink a bit. Okay, this is a temporary condition that'll eventually correct itself as we begin to eat more, right? But if you take in more than the stomach can hold, then you're going to promote either gastric emptying, like into the small intestine, right? And we know what happens there, which is that you can end up with the stomach acid damaging the lining of the duodenum, right? The first part of the small intestine. But it could also promote emesis. You could throw up, right? So you have to approach this slowly, or you expand the stomach slowly. Position to increase gastric motility, which means sit up. Okay. Give mouth care before or after meals, and this is for the same reason that we do it for people that are experiencing emesis for other reasons, right? The the um, the acid is going to erode the oral cavity. It's going to erode the esophagus, and it's going to erode the enamel on the teeth. Okay, so this is important. Got to clear that acid out so it doesn't continue to do damage. Okay, constipation and diarrhea are two ends of sort of the same problem. All right, in constipation, what happens is that the fecal material moves through the large intestine too slowly. And that means too much water is pulled out of the fecal material and it becomes so solid that it's difficult to pass. And this can happen for a variety of reasons. Risk factors include old age and low fiber diet. Okay, those are just a couple, but there's also pain meds like oxycodone that can bring this on. All right. If you have irregular bowel habits or IBS, okay, irritable bowel syndrome, this can cause irregular movement in the bowel, right? And irregular can also mean less movement, right? Other risk factors, pregnancy, okay, inadequate consumption of fiber and fluid, all right, rectal trauma, such as in sexual abuse or in childbirth, okay, can be a problem as well. There could be another obstruction in there. Okay, there could be a polyp or some other benign tumor, or there could be a problem in the orientation of the large intestine where you've got a twist or a buckle. Okay, so what we want to do is a high fiber diet, all right, which is 25 grams a day for women, 38 for men, enough fluid intake to alleviate the constipation, all right, and then probably a fiber-based laxative, okay, would be on the medication list. If it's caused by a med, you need to change the med, right? I pointed out, for instance, things like oxycodone can promote constipation because the way it interacts with the nerve endings that tell the muscle in the digestive system to push, okay? This is often why if they give you oxycodone, they give you laxative at the same time, okay, in order for you to be able to clear the fecal material, all right? So we either combine it with a laxative or we reduce using that particular med. What do you do as a dietitian or a nurse? You're going to determine the onset and the duration, okay? You're going to try and look at past and present elimination patterns. Like how many times normally do you go in a day? Okay. Look at their dietary intake, look at their stress levels. Okay. Get a patient history, right? What are their meds? What's their surgical history? Okay. Are they using any supplements? Presence of rectal pressure or fullness and abdominal pain are important. Okay. Tell the client to increase the daily intake of fiber. Tell the client that an increase in fiber intake is the preferred treatment, and chronic use of laxatives you want to prevent because you can go too far in the other direction. Diarrhea is the opposite. In diarrhea, the fecal material is moving through too quickly. And so we're not pulling enough water and electrolytes out to put back into the blood. So it's shooting through the large intestine much more rapidly than we want. And the problem here is you can lose fluid and you can lose electrolytes. And this is particularly worrisome in the aged or in the very young. Okay. So what are some causes? Emotional and physical stress, GI disorders, malabsorption disorders, infections, and certain medications. Okay. So again, when you're assessing this, you have to determine the underlying cause, right? If the patient isn't under any stress, okay, and they don't have any long-standing disease, let's say something like pernicious anemia or lactose intolerance, right? And they're not on a med that normally causes problem, then what we have is an infection, right? And just like with emesis, diarrhea is an attempt to clear the irritant out of the tract, okay, in the case of an infection. Okay, so if an infection is indicated, then what you want to do is just replace what's lost by the diarrhea and not try and take medications to reverse the condition. Okay, like Imodium. So you let the diarrhea run its course, and then you clear the infection, and then you can go back to a normal diet. A high fiber diet is often prescribed unless the fiber is the cause of the diarrhea. You want to check fluid and electrolyte loss. Nutrition therapy varies with the severity and the duration of the diarrhea. You want to increase fluid intake to replace losses as needed, right? Because you're losing stuff out the back end, you got to replace it in the front end. So usually they might recommend a sports drink or some other formulation that's got the electrolytes and the fluids in it in order to keep you functional. Okay. So one of the things that happens as we get older, right, is that we tend towards constipation instead of diarrhea, because what happens is that the muscle in the lining of the colon and the digestive system as a whole gets weaker. And as it gets weaker, it's less capable of pushing, and less capable it is of pushing, the longer the fecal material spends in the bowel, the more water we're going to pull out, the more constipation is going to happen. And that's why we recommend higher fiber liquid intake as you get older in order to make this stuff easier to pass. Okay. I think I've talked before about the fact that in the case of constipation, if the fecal material sits too long, it'll actually mineralize. It'll turn into rocks, which we call fecaliths, and those have to be removed manually or surgically in order to clear. Okay. And so that's what we want to avoid. All right. Okay. Dysphagia is a problem with swallowing. Okay. Causes can be obstruction, inflammation, and then there's neurological disorders that keep you from swallowing properly. You want to change the texture of food and the consistency of liquid so that the client can get proper nutrition. Dry mouth can contribute to dysphagia. Evaluate meds being taken to determine if this has a potential adverse effect. Clients who have dysphagia are at an increased risk of aspiration. Place the client in an upright or high Fowler's position to help them swallow. Give oral care prior to eating to help the client's sense of taste. Clients who have dysphagia should be referred to a speech therapist for evaluation. Dietary modifications are based on specific swallowing limitations that the client's experiencing, and you want to stop thin liquids or sticky foods. Now, you might have a question about speech therapists with this dysphagia, right? Now, the reason that this could be useful is because sometimes when you can't swallow, what you have is a defect in the swallowing apparatus. Okay, there could be something that was the result of trauma, or there could be something that you're born with. Okay, you might have, for instance, weakened musculature in the pharyngeal constrictors. Those are the muscles that squeeze food down your throat into your esophagus. Okay, you might have an abnormal shape to your throat, or you might have something in your throat that's blocking it, right? Like your tonsils could be enlarged. That's one example of a problem you could have with dysphagia. Okay, if you're heavy, all right, then you might have dysphagia because the extra weight around the neck can cause closure of the throat. Okay, so there's all sorts of underlying conditions here that you need to look at with swallowing to make sure that there's not a physical problem involved that can be corrected surgically or with therapy. Okay, what do you do as a nursing intervention? Allow time for eating. Use adapted eating techniques, small bites and thorough chewing. Pills should be taken with at least 8 ounces of fluid. You can thicken this if you want, such as with applesauce. You want to stop meds from remaining in the esophagus too long, right? Nutritional supplements are important if the nutritional intake isn't adequate, right? So if they can't get a lot down, you can help them get the nutrition they need by giving it to them in a concentrate, okay? Now, dumping syndrome is something that's often an outcome of gastric surgery, okay, like stomach staple or lap band, all right? Or uh, they sometimes have a surgical procedure called a bypass, right? Or they hop over certain parts of the small intestine and reattach the stomach to areas, say in the further down in the small intestine, right? They might even shorten the amount of duodenum that's involved. Okay? And most of these are done to deal with obesity. The idea is that the smaller the stomach is, or the less chance the food has to absorb into the blood and the lymph, then the less weight you're going to gain and the more weight you're going to lose. Okay. And sometimes it's effective and sometimes it's not. Right. In dumping syndromes, what's happening is that the stomach is just saying, okay, it's all coming out at once because I can't hold it. Okay. Normally the stomach is going to control how much it empties into the duodenum with small squirts. But if it's been surgically altered, sometimes it'll just throw the entire liquid contents of the stomach into the small intestine at once. And the problem with that is that the pancreas and the gallbladder can't keep up with that because they don't release enough in in a single in a single squeeze to neutralize all that stomach acid or to emulsify all that fat. So what do we see? Usually 15 minutes to a half hour after eating, we'll see a sensation of fullness, cramping, diarrhea, nausea, um, faintness. You may even faint. You'll have sweating, tachycardia, that's rapid heart rate, low blood pressure, and flushing, right? So something's not right. Late symptoms, 1 to 3 hours after eating, sweating, weakness, tremors, anxiety, nausea, hunger, okay? Symptoms usually resolve once the intestine is empty, but there's usually a rapid rise in blood glucose and an increase in insulin levels immediately after the intestine empties, and this can lead to hypoglycemia. All right. So in hypoglycemia, we get that weak in the knees feeling. We'll feel faint. Okay. And what we need is intervention with some sort of carbohydrate, simple carbohydrate. So we recommend small, frequent meals. We recommend eating protein and fat at each meal. Tell the client to stop food that contains concentrated sugar and restrict lactose intake. Tell the client to consume liquids an hour before or after eating instead of during the meal. Okay. I tell the client to lie down for about half an hour after the meal to delay gastric emptying. If reflux is a problem, tell them to recline, not too far, okay, but maybe like a modified Fowler's, okay. Check clients receiving enteral tube feedings and report symptoms of dumping to the provider, right? So tell the doc or the head nurse what's going on. Check the client for vitamin and mineral deficits, such as iron and B12, right? We need those to make blood, right? So if they're not getting that, they're going to become anemic, okay? So this is the kind of thing you look for when you're dealing with somebody that has had stomach surgery, or sometimes this occurs in individuals that are obese or pregnant, okay, because of the pressure on the stomach. So that's your risk group right there. Okay. So let's take a look at GERD and understand it a little bit better.
Gastroesophageal reflux disease is also known as reflux or GERD. This occurs when the muscle between the esophagus and the stomach, the lower esophageal sphincter, is weak or relaxes inappropriately. This allows the stomach's contents to back up into the esophagus. Symptoms include heartburn, belching, and regurgitation of food. Most GERD sufferers have frequent, severe heartburn that tears down and damages the cell wall lining of the esophagus. Without treatment, GERD can lead to the following conditions: Barrett's esophagus, a precancerous change in the cells lining the esophagus; esophageal cancer; esophageal perforation, or a hole in the esophagus; esophageal ulcers, which damage the lining further; esophagitis, inflammation of the esophagus; esophageal stricture, a narrowing of the esophagus that interferes with eating. Dietary and lifestyle choices may contribute to GERD. Certain foods and beverages, such as chocolate, fried or fatty foods, coffee, or alcoholic beverages, may weaken the lower esophageal sphincter, LES, and cause reflux and heartburn. Studies show that cigarette smoking relaxes the lower esophageal sphincter. Obesity and pregnancy can also cause GERD. Decreasing the size of portions at mealtime may help control symptoms. Eating meals at least 2 to 3 hours before bedtime may lessen reflux by allowing the acid in the stomach to decrease and the stomach to empty partially. Treatment for GERD can include medications such as Zantac, Prilosec, and Nexium, as well as surgical procedures.
So what's happening is that the contents of the stomach aren't staying in the stomach. Instead, what they're doing is they're shooting up into the esophagus, and the acid in there is eroding the lining. And it's going to inflame the esophagus and scar it and make it bleed. And if that happens, you can end up with Barrett's esophagus, which is a cancerous to precancerous condition. In the short term, you can end up closing the esophagus off, and that means you can't get much food into the stomach. Okay. Factors that contribute. Well, hiatal hernia. What is that? That's where the fundus of the stomach, which is the top of it, pops through the diaphragm and into the thoracic cavity, and then the muscles of the diaphragm close around the fundus, and that's going to make it difficult for food to enter the stomach. Okay. Hiatal hernia risk groups are individuals that are obese or pregnant, okay, because of the pressure on the stomach pushing it up through the hiatus. But older people can get this as well because of weakness in the diaphragm, okay. Smoking and certain medications can contribute to this as well, all right. And the symptom is heartburn, okay. And I know it has kind of a funny name to it, heartburn. It's obviously not your heart that's producing this condition. The pain is coming from your esophagus, okay. This is actually, when you talk about GERD, this is esophagitis, all right, inflamed esophagus, and probably accompanied by gastritis, which is inflammation in the stomach, okay. So actually, a stomach ache, in a sense, is GERD, okay. And what we often colloquially refer to as a stomach ache, where we grab our abdomen and say, "I have a stomach ache," that's called enteritis, all right. That's pain in the lower GI, right? So we've misnamed some things when we talk about them colloquially using our own language, okay. Long-term GERD can cause adenocarcinoma of the esophagus and Barrett's esophagus. Symptoms are heartburn, retrosternal burning, that's behind your breastbone, right? Painful swallowing, dyspepsia, that's stomach ache, right? Regurgitation, emesis, right? Coughing, hoarseness, epigastric pain. We all remember where the epigastric region is, right? Pain can be mistaken for an MI sometimes, okay? And that's just because of the location, all right? Tell the client to stop situations that lead to increased abdominal pressure. Um, what are some of those situations? Pregnancy, obesity, tight fitting clothing. All right. Tell the client to stop eating 2 hours or less before they lie down. Why? Because you want to make sure that the material clears the stomach before you lie down and put extra pressure on the stomach by lying down. And don't sleep on your stomach. Okay. Sleep on your back. Tell the client to raise the body on pillows instead of lying flat, and to stop large meals and bedtime snacks. Right. Obviously, don't eat at night. Recommend weight loss for clients that are obese, and for those that are pregnant, indicate to them that once the baby is out, then these problems should correct. Right. Tell the client to stop trigger foods such as citrus fruits or spicy foods or carbonated beverages. Those are triggers for some people. Tell the client to stop items that reduce lower esophageal sphincter pressure, including fatty acids, or I'm sorry, well, fatty foods, caffeine, chocolate, alcohol, cigarette smoke, nicotine products, as well as peppermint and spearmint. Okay. So let's take a look at gastritis and peptic ulcer disease.
This is Dr. Carlo Ojet, Medical Director at Capital Regional Medical Center with Titan Emergency Group. Today I want to talk to you about gastritis versus peptic ulcer disease. Peptic ulcer disease is an open sore in the lining of the stomach. An infection in the stomach like H. pylori is the cause of most ulcers. Other causes include cigarette smoking, anti-inflammatory drugs such as ibuprofen, prednisone, and aspirin, and emotional stress. Acid blocker medicines will help to heal the ulcer in 6 to 12 weeks. If a bacterial infection is present, antibiotics will also be needed to keep the ulcer from coming back. As you can see in the picture, there is an erosion in the lining of the stomach going into the deeper layers of the stomach. When severe, a peptic ulcer can perforate, causing severe abdominal pain, pancreatitis, and becoming pretty ill. Gastritis is an irritation of the stomach lining without an ulcer. Causes include excess of alcohol, anti-inflammatory drugs, and spicy foods. The symptoms of these two diseases are very much alike, and most of the time we can't tell the difference on emergency department analysis by itself. Further tests may be needed to tell them apart. Both will be helped by the following measures. Home care. Take any prescribed medicines for as long as directed. Finish them even if you begin to feel better sooner. Unless an acid blocker was prescribed, you may use over-the-counter drugs such as Pepcid AC, Zantac, etc. These begin to work within a few hours. Prilosec over-the-counter is a new type of acid blocker which may be more effective. It takes up to 4 days to take its full effect. You may get additional short-term relief by taking antacids like Malanta or Maalox. It should be taken 1 hour after meals and at bedtime. Gastritis may be worsened by foods that irritate the stomach. Follow a light diet until you're feeling better. Avoid the following: aspirin and medicines that contain aspirin, anti-inflammatory medicines such as ibuprofen and naproxen, alcohol, caffeine, tobacco, acidic foods such as tomatoes and citrus, lemons, grapefruit, and oranges. Prednisone and related prescription drugs can cause an ulcer. Discuss with your doctor if you're taking any of these. Follow up with your doctor is very important. He can order further testing. He can refer you to a GI specialist for endoscopy if necessary. He can order H. pylori testing to find out if your gastritis or ulcer is caused by these bacteria and whether or not you need antibiotic treatment. This specific diagnosis is not usually done in the emergency department. When to seek prompt or emergency medical attention. Stomach pain begins to get worse or moves to the right lower abdomen, the appendix area. Your abdomen becomes distended or swollen with frequent vomiting. You're not able to keep fluids or food down. If you have diarrhea, if you feel weak and dizzy, fainting, or trouble breathing, if the pain starts to spread into your chest, back, neck, shoulder, or arm. You start vomiting with blood, red or black color, if there's blood in your stool. If by any means your condition deteriorates and you're not improving, do come back for reevaluation. We hope you get better soon, and we want to thank you for trusting your care to us here. God bless you.
So with acute and chronic gastritis, you're just talking about a difference in how quickly the symptoms show up. With acute gastritis, it happens right away. And with chronic gastritis, it's slow in coming, but it lasts for a longer period of time. Okay. What do we have? We have inflammation of the stomach. That's literally what the word means, right? The gastric lining is congested with blood and fluid and it gets inflamed. There's less acid made and there's too much mucus, and you can get ulcers, and that sometimes leads to bleeding, right? Gastric ulcer. We're going to see last week that can be caused by bacteria like Helicobacter pylori, right? But there are also meds that can make it worse. Aspirin and ibuprofen can thin the mucus that the stomach makes and cause the acid to erode the lining more quickly, okay? Acute gastritis occurs with too much NSAID use. NSAID is an acronym that stands for non-steroidal anti-inflammatory drug. Think ibuprofen, naproxen, aspirin. Okay, it can be caused by bile reflux, ingestion of a strong acid or an alkali, such as when you're perhaps trying to neutralize something that's been ingested, or as a part of your diet, or as an accidental ingestion. Okay. It can be a complication of radiation therapy because radiation therapy attacks the lining. Well, it attacks any epithelial tissue because epithelial tissue rapidly divides. Radiation and chemotherapy are going to thin those tissues out. And as a result, they're easier to damage. Okay? That's why a lot of patients that are on radiation or chemo need treatment for a lot of different GI issues. Okay, it could be a complication of trauma, such as chemical burns, right, or food poisoning or infection. Okay, liver disease, kidney disease, respiratory failure, major surgery can all be contributing factors here. Chronic gastritis can occur in the presence of ulcers. Helicobacter we've discussed, right? Helicobacter can colonize the stomach lining and cause inflammation that leads to erosion, that leads to bleeding, right? And in a worst case scenario, it can actually puncture the stomach, and then the gastric juice leaks out into your abdominal pelvic cavity and starts to digest your internal organs, and that's an immediate medical emergency. Okay, autoimmune disorders can be a problem here, right? Autoimmune disorders are where your immune system attacks your own tissue. Examples can include pernicious anemia, right? Poor diet can be a problem, right? Too much caffeine, too much alcohol intake, okay? Medications such as pyranopril or alendronate, all right? And reflux of pancreatic secretions and bile into the stomach can be a problem as well. What do we see? Abdominal pain, which can be relieved when you eat, headache, lethargy, that's just basically being sluggish, nausea, anorexia, hiccuping, heartburn after eating, belching, sour taste in the mouth. Now you might wonder, well, what's that about? That's acids coming up. Okay, acids taste sour, right? Think citric acid in things like oranges and grapefruits. Okay, vomiting, bleeding, and hematemesis, which is to throw up blood. Okay, so be on the lookout for that coffee ground appearance. Acute recovery usually occurs in about a day, but can take maybe a couple of days to resolve. The client needs to have a bland diet, and when able to tolerate food, you might need IV fluid replacement if the condition is ongoing. When this occurs due to ingestion of strong acids or alkalis, we want to dilute and neutralize the problem here. So stop lavage and emetics because you don't want that stuff to come back up and damage the esophagus. Okay. and puncture anything. What you want to do is neutralize whatever's been ingested. Okay, an example, a classic example of this is the story of the infant accidentally ingesting oven cleaner lye, okay, which is a powerful base. All right. And the last thing you want to do is induce vomiting, because if that comes back up, that's gonna erode the esophagus and the pharynx and the oral cavity. Okay, your esophagus, your throat, your mouth, right? So what you want to do is neutralize the lye, and you do that by ingesting an acid, okay, usually a weak acid, and then sometimes you might want to take something that has a buffering effect as well. Tell the client to stop eating frequent meals and snacks because they promote too much acid secretion, and then stop alcohol, cigarette smoking, and then any of those NSAIDs that we talked about, right? Because they thin that mucus. You want to stay away from coffee, black pepper, spicy foods, and caffeine. Um, the coffee, the black pepper, the spicy foods, the caffeine, all can be irritants. Okay. Check the client for vitamin deficiency, especially B12. Remember that B12 is absorbed across the lining of the stomach using a special protein called intrinsic factor, which allows it to move into the blood, right? And if you damage your stomach lining, then you don't make as much of that protein. You can't get the B12 into the blood, which means you can't make blood, right? Because the B12 is important for making DNA, which is important for the cells that make blood to survive. Okay, and they're in your red bone marrow. Let's look at peptic ulcer disease.
Normally, gastric juices are secreted in the presence of food. Stress and smoking can also cause the stomach lining to secrete gastric juices. In the absence of food, the acidic juices erode the lining of the stomach, leaving an open sore that may bleed. This open sore is called an ulcer. Recent research has shown, however, that a bacterium, Helicobacter pylori, may be a major factor in ulcer formation. The use of antibiotics to kill the bacteria has proved quite helpful in treating many patients with ulcers.
And that's not to say every ulcer is caused by Helicobacter, but it is a major player. And we pointed out that only certain individuals are going to be prone to colonization by that bacteria, right? You have to have the right genetics for the bacteria to be able to latch on to your stomach lining and do its dirty work. Okay. With peptic ulcer disease, we have an erosion of the mucosa in the stomach, or if it's a duodenal ulcer, it's in the duodenum, that's in the small intestine. Okay. This can be the result of Helicobacter infection, or it can be the result of chronic NSAID use. Some clients who have this problem don't experience any symptoms, and others have a dull, gnawing pain, a burning sensation in the back or the low med epigastric area. Okay, now you can understand why it would be in the epigastric area, but how about this sensation in the back? Well, that's something called referred pain. Okay, and that happens when pain is coming from an area of the body that isn't really the location of the pain, and that's because the pain leads from that part of the body, and the pain leads from the organ that's actually hurting, go into the central nervous system in the same spot, and they ring on the same pain line in the brain, and the brain can't distinguish between the two. Okay. So what else do we see? Okay, heartburn, constipation, diarrhea, sour taste in the mouth. Again, that's gastric juice in the oral cavity. Burping, nausea, vomiting, bloating, urea in the breath, and a tarry stool. And that's because there's bile in there. Okay. Eating can temporarily relieve the pain, and anemia can occur due to blood loss. If it's caused by Helicobacter, then there are some antibiotic combinations that can wipe out the infection. Okay. And acid reducing medications can reduce the erosion of the lining, slow it down. You take that for a couple of weeks. Tell the client to stop eating frequent meals and snacks because they promote increased acid secretion. and tell the client to stop with coffee, alcohol, caffeine, aspirin, NSAIDs, cigarette smoking, and spicy or hot foods, right? Lactose intolerance is another one of these special cases, okay? In lactose intolerance, what happens is that the client doesn't make enough lactase, which is the enzyme that breaks down lactose into galactose and glucose so that it can be absorbed into the blood, right? So what happens instead is that the lactose stays in your small intestine and works its way all the way to the colon, where the bacteria in the colon use that for fuel, and they overgrow and produce gas and pain and distension, and that can lead to diarrhea or constipation, okay? Gas, all right, cramps. Tell the client to stop or limit their intake of foods that are high in lactose. Or you've got to take the enzyme lactase, okay, in order to break down the lactose, right? And then there are dairy products, alternate dairy products that are that have been cleared of their lactose as well. And there are also dairy products that have the lactase in them. All right, so those are some alternatives that are out there. Tell the client to ask the provider about the use of lactase, and then check for vitamin D deficiency and calcium. Okay, because if you're taking dairy out of the equation as part of your treatment, then you're removing a vitamin D source, right? So you need to put that back somehow. Calcium, the same deal. Okay, there are replacements for that, right? There are a lot of green leafy vegetables that are high in calcium and some that contain vitamin D. Okay. With an ileostomy or colostomy, what happens is we're bypassing the normal route of the digestive system and we're diverting the material into a bag. Okay. This can be a temporary or a permanent setup. Okay. It's often a temporary setup if we're doing something called a bowel resection. And in a bowel resection, what happens is that part of the bowel has become non-functional. It's either not squeezing food through or it's been damaged. Okay. And the result is we have to remove that section, right? And then temporarily, we've got to divert the fecal material into a bag that's attached to a port that's coming out of your abdomen. Okay. And then if in the future we end up with material that allows us to rejoin the resected bowel back to the rectum and the anus, then the second surgery can reverse the colostomy and we can restore flow. Okay. An ileostomy is essentially the same thing, but with the small intestine. All right. So you're routing the material from the ileum into a bag. Okay. The colon absorbs a lot of fluid, sodium, and potassium, and nutrition therapy begins with liquids only, and then we go further based on what they can tolerate. We want to tell the client to consume a diet that's high in fluid and fiber in order to, again, keep the material that is diverted into the bag capable of passing through the port, right? Tell the client to stop foods that cause gas or stomal blockage, such as nuts or raw carrots or popcorn, and foods that produce odor. Okay. Tell the client to increase their intake of calories and protein to promote healing of the site. Okay. And give emotional support to clients because of the risk of an altered body image. Now, another important point to address at all times is to make sure that the stoma doesn't get infected, okay? Because of the nature of the material coming out of the port and the nature of the location of the stoma, right? You have the potential for infection that could spread to the abdominal pelvic cavity, all right? So you have to check the site for inflammation, swelling, etc. Okay? Let's take a look at diverticulosis and diverticulitis.
Diverticulosis is a condition in which small pouches grow in the lining of the colon and sometimes begin to bulge through the colon wall. A single pouch is called a diverticulum. The plural word is diverticula. Diverticulosis is therefore known as a diverticular disease. In 10 to 25% of cases, diverticulosis precedes a similar condition called diverticulitis. This disorder occurs when diverticula become inflamed. Let's take a look at some of the possible causes of diverticulosis. Although conclusive evidence is lacking, it appears diverticulosis may result from the lack of fiber in the patient's diet. Researchers have noticed that diverticular diseases became much more prevalent in the U.S. early in the 20th century when processed foods became more common. Processed foods generally have less fiber. The more processed foods you eat, the less fiber you get. Diverticular disease is also more common in developed or industrialized countries, which adds credence to the theory that low fiber diets promote diverticulosis and diverticulitis. Diverticular disease is rare in Asia and Africa, where people generally eat a lot more fiber. Symptoms of diverticulosis. Those who have diverticulosis generally don't experience any discomfort or symptoms. Occasionally, however, there could be mild cramping, bloating, and constipation. You should note, however, that some other problems like stomach ulcers and irritable bowel syndrome, or IBS, present similar symptoms, so diagnosis is not always that easy. Treating diverticulosis. Lifestyle changes are usually the best treatment for diverticulosis. Adding more fiber to the diet reduces diverticular problems, although mild pain medications may be prescribed in certain cases where abdominal pain or discomfort is present. If you have diverticulosis, it's important to make sure there's a lot of fiber in your diet. Fiber provides bulk and helps you move food through the colon. Good sources of fiber include oat bran, wheat bran, and of course, fruits and vegetables. Drinking a lot of water helps, and you may want to consider adding a fiber supplement such as ground flaxseed. This can be especially good for relieving constipation should it occur. If you're experiencing symptoms of diverticulosis, your best source of information, of course, is your doctor, and you should always only act on his or her advice. Meanwhile, though, here are some other resources you may find a bit helpful. Just click on the links below this video to get more information about them.
So what happens in this condition is that the lining of the large and small intestine get weak. And when that happens, you get these little pouches that that occur called diverticula. Okay, and by themselves, they're not a problem. What causes problems is when material collects in the diverticula, and then bacteria colonize that, and they get infected. All right. The result then is you get all the conditions that you would associate really with the case of something like appendicitis, right? Except for the location being different. The inflammation occurs when fecal matter gets trapped in the diverticula. It's the same thing that happens in appendicitis. So we see abdominal pain, nausea, vomiting, constipation, diarrhea, fever, chills, and tachycardia, right? So we give antibiotics, anticholinergics, and analgesics. Clients who have severe symptoms are admitted to the hospital, and the dehydration is treated with IV therapy. So we do fluid replacement. Opioid analgesics are given for pain. Complications such as peritonitis, bowel obstruction, or an abscess need surgical intervention. Okay, so again, the progression of this, if we don't do anything about it, is the same as the progression of appendicitis, right? The little sac has fecal material in it, and the fecal material are bacteria, and the bacteria are producing gas, all right? And the bag is swelling up, and it's getting inflamed, and the bag is probably blocked, okay? And the danger is it could pop. And if it pops, then all that nasty stuff is in your abdominal pelvic cavity, and that's going to infect the peritoneum, lead to peritonitis, and then that could lead to septicemia, and that could lead to death. Okay, so this is what we're looking for, right? So what do we do about this? A high fiber diet, okay, generates stools that are easily passed and decreases pressure in the colon. During acute diverticulitis, clear liquids are prescribed until inflammation decreases, and a high fiber, low fat diet is indicated. Tell the client to stop foods with seeds or husks, and note that clients require instruction regarding diet adjustment based on the need for an acute intervention or a preventive approach, meaning we may have to take you into the emergency room and deal with this immediately, okay, ASAP, all right? Let's look at IBD.
Irritable bowel syndrome, or IBS, is a chronic condition affecting your large intestine. Your large intestine, also known as your colon, includes the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. The muscular wall of your colon contracts in a rhythmic fashion called peristalsis to move the intestinal contents toward your rectum. As it contracts, your colon absorbs water and nutrients from partially digested food moving through it. Waste material, called stool, is stored in the rectum until it is expelled through the anus as a bowel movement. With IBS, the muscular contractions of your colon are abnormal. In some cases, the contractions may cause food to move too quickly through your colon. As a result, your colon does not have enough time to absorb most of the water from your food. This condition leads to a watery stool and diarrhea. In other cases, the contractions may cause food to move too slowly. As a result, your colon absorbs too much water from your food. This condition leads to a hardened stool and constipation. It is unclear why your colon contracts abnormally. However, if you have IBS, your colon may be more sensitive to certain factors such as stress that seem not to affect most people. Other symptoms of IBS include abdominal pain and discomfort, bloating, gas, and cramping. You can manage your IBS symptoms through a combination of dietary habit changes, stress management, and medications. Eating food high in fiber creates softer, bulkier stools, which may prevent spastic colon contractions. Fiber also helps relieve constipation. Stress management therapies, such as hypnotherapy and yoga, may help relieve your symptoms. Your doctor may prescribe medications to help manage your symptoms, such as anti-constipation drugs to help regulate your bowel movements, antispasmodic drugs to minimize muscle spasms and reduce pain, or sedatives and antidepressants to relieve anxiety and elevate your mood.
So an example of this is Crohn's disease, right? Which sometimes is called regional enteritis. Ulcerative colitis is another type of IBD, all right? And so we see times when this is really bad and in times when this will go into remission, right? We see nausea, vomiting, cramps, fever, fatigue, weight loss, steatorrhea, which is floating stool, and fever. Nutrition therapy is focused on giving nutrients in forms that the client can tolerate. Generally, the diets are low in fiber, and that's to minimize bowel stimulation. Okay. Tawana, I see a question from you regarding the quiz. Yeah, I'll talk to you after class where it's at. Okay, it's in the calendar. A low residue, high protein, high calorie diet with vitamin and mineral supplement is prescribed. Fluid and electrolyte imbalance is corrected with IV fluid or oral replacement. Other therapies include sedatives, antidiarrheal and antiperistaltic agents, aminosalicylate meds, and corticosteroids, and that's to deal with inflammation. Okay, and remember with corticosteroids, you can't stay on those long term. Okay. Immunodilators alter the immune response. Immunomodulators change the immune response and stop relapse. And surgery when other treatments aren't effective. What do we do as a nursing intervention? stop the intake of stuff that causes or worsens the diarrhea, and stop nicotine. So this is going to be patient specific. TPN is used for clients who are severely ill during the acute phase of the illness. Now you might say, what is TPN? Okay, well, we're going to get to parenteral nutrition towards the end of the course, and this is where you have to get your nutrients through IV. Okay, because you can't tolerate them going through the GI. And this is a perfect example of a problem here with the GI functioning. Okay, so in TPN, we give you your vitamins, your minerals, your nutrients all through a tube and go directly into the bloodstream. Okay. Let's look at cholecystitis.
Bile is stored in the gallbladder. Normally, the cholesterol in the bile remains in solution. Under certain conditions, the cholesterol may precipitate and form solid crystals. If this process continues, the crystals grow larger and become gallstones. The stones may block the flow of bile, causing pain and jaundice. Gallstones may be removed surgically.
The idea here, right, is that these crystals aren't letting the bile get into the small intestine. If this isn't treated, what could happen is that the gallbladder could rupture. Okay.
Bile,
and that's going to lead to infection. Okay. These little stones that occur are due to the fact that too much water is pulled out of the bile, and you generate these little crystals that don't dissolve very well. Okay. There are okay, there are medications that can dissolve the gallstones. Okay, but in the event that that can't be done, we have to intervene either with lithotripsy, which are sound waves that can tear up the stones, or we have to go in surgically. Okay. So what do we see? We see pain and tenderness and rigidity in the upper right abdomen. Pain can radiate to the right shoulder or the mid-sternal area. Now you might say again, why there? And this is referred pain again. Okay. Nausea, vomiting, anorexia can happen. If the gallbladder becomes filled with pus or gets gangrenous, then it can puncture, right? And there we have that break in containment that I'm always talking about, where a compartment of the body that's not supposed to be exposed to the outside world suddenly is. Okay, and now we have the huge risk of infection. In clients who have big stones or the inability to control the condition with diet modifications, surgery is needed. Pancreatitis and liver involvement can result from uncontrolled cholecystitis. Now, why is that? Well, if you jam the hepatopancreatic sphincter, which is where the pancreatic duct and the bile duct come together before they dump into the small intestine, you block two organs at the same time from releasing their material into the small intestine. And so they both get inflamed, right? The danger with the pancreas getting inflamed is that it can end up digesting itself, right? And so now you don't have a source of bicarbonate or pancreatic enzyme. The problem, of course, with the gallbladder getting blocked is it can burst. Okay. So what do? Fat intake is limited so that the gallbladder quits squeezing, right? The gallbladder squeezes harder the more fat that gets dumped into the small intestine. Okay. Other foods that cause problems include coffee, broccoli and cauliflower, Brussels sprouts, cabbage, onions, beans and peas, and highly seasoned foods. Let's look at pancreatitis. There we go.
So pancreatitis is a condition where there's just inflammation of the pancreas. It can be acute, meaning just comes on suddenly out of the blue, terrible, searing upper abdominal pain, brings you to the hospital, and most people are admitted. But then there's another variety, it's called chronic pancreatitis, where there's just chronic inflammation of the pancreas, and people have chronic abdominal pain and go on for months to years. You know, we know that heavy alcohol use is associated with chronic pancreatitis, but it turns out that's probably a minority of individuals. And what we're realizing is that many patients, whether they're age 4 or 6 or they're age 50, that they have unexplained chronic inflammation of the pancreas. The pain of chronic pancreatitis is probably one of the worst pains that people can have. Every meal that you eat makes the pain worse because when you eat, you turn on the pancreas. Probably the best analogy that I think most of my patients would say is that it's like 30 lit cigarettes dropped into your upper abdomen and left there to smolder. If the tests such as a CAT scan or MRI are abnormal, then that helps make the diagnosis. But in about 20–30% of patients, those tests can be normal. And then the problem is how do you make that diagnosis? Blood tests are normal. So a lot is kind of sitting down with the patient, going through a careful history, and trying to figure out, is it other things or not? Here at Beth Israel Deaconess, we do this called secretin pancreatic function test. So if your CAT scan and MRIs have been normal, we do this other test. It's a relatively simple upper endoscopy procedure. We can rule in or rule out the diagnosis of chronic pancreatitis. I think it's important that we treat the pain these patients have, but one of the problems is, do we put them on lots of narcotics? And there's a lot of issues with that. I think we should try to control the pain as much as we can, but when you start giving large amounts of narcotics, people get more used to them, and after a while, they don't work. We've been trying to look at other alternatives. So for example, if, let's say someone says, go ahead, doctor, just cut out my whole pancreas. Well, you have a 50% chance you'll have your exact same pain of chronic pancreatitis. So even if you remove the whole pancreas, your brain is still getting the sensation that my pancreas hurt. And probably it's like phantom limb pain. Cut off your leg, you still feel it there because that sensation's been there so long. And that's our approach now with transcranial magnetic stimulation, this research study that we were doing. And it's just one approach where we're going after mechanisms in the brain and non-invasively try to modulate them. It's not the only approach though. Mind-body, we have meditation that works for some people. Once in a while, things like celiac nerve blocks can work, and then some other medications will occasionally use. Eventually, the pancreas tends to go burn itself out, whatever that means. But usually, people's pain, as mysterious as it started, just goes away. I think right now there aren't a lot of magical cures. My group has been one of the people in the country that's taken the lead on identifying what gene mutations are responsible for chronic pancreatitis. But there are, though, a lot of potential hope, some new avenues. We still have a long way to go, but at least we can potentially give someone the diagnosis of why they have chronic abdominal pain. Is it chronic pancreatitis? And if so, what's a thoughtful plan to really help that person and their family get back on keel and have somewhat of a normal life back?
So pancreatitis, definition of the word is inflammation of the pancreas. It's important for secreting enzymes needed to digest fats, carbs, and proteins. What do we do as a nursing intervention? For acute pancreatitis, we do NPO, right? don't use the digestive system because it's not working, right? An NG tube is inserted to remove gastric contents, and then we put them on parenteral nutrition, which is again nutrients and minerals and vitamins by IV. Okay. Nutritional therapy for chronic pancreatitis includes a low fat, high protein, high carb diet, and it can include providing supplements of vitamin C and B complex. Okay. Bottom line here, we're trying to save the pancreas and reduce the work that the pancreas has to do. Okay. In an effort to try and allow you time to recover. Okay. All right. Liver disease. Liver is so important that if your liver um, ends up acquiring a condition in which it can no longer function, such as cirrhosis or cancer, um, that is going to remove your liver function, that's a death sentence. That's why the first 4 words in the word liver spell live. That's not a coincidence. Disorders affecting the liver, cirrhosis, hepatitis, and cancer. Hepatitis is a blanket term meaning inflammation of the liver, and that can be caused by viruses, toxins, and excessive alcohol and recreational drug use. Malnutrition is common with liver disease because the liver is responsible for, again, serving as your body's kitchen and pantry. Meaning what? Meaning it stores excess calories as glycogen or fat for later use. And then when your blood nutrition levels drop, the liver takes that stored material and converts that into sugars that can be used by the tissues for energy. Okay, so if your liver checks out on you, then essentially one of the things that's going to happen is that all your tissues are going to starve. Okay, so what do? Protein needs are increased to promote positive nitrogen balance and stop the breakdown of the body's own protein. Carbs are generally not restricted because they're an important calorie source. Calorie requirements might need to be increased based on an evaluation of the stage of the disease, their weight, and their health. And multivitamin and mineral supplements may be important. Avoid alcohol, nicotine, and caffeine. Why? Because one of the liver's other jobs is to detoxify your blood, and that includes detoxifying both recreational drugs, alcohol, and medications, right? And so if we put an extra load on the liver, having to do that when the liver is already compromised, the liver is likely to fail, right? And that would be your death. Let's take a look at celiac disease.
Patients with celiac disease come in all shapes and sizes and all ages, so they can present at any age. Well, celiac disease is a reaction of the immune system in the intestine to certain proteins, and the proteins come from wheat, barley, and rye. Those proteins, which we collectively term gluten, are generally considered something that is good for us, but for patients with celiac disease, and probably for some genetic reasons, their immune system reacts against it and sets up a inflammation or damage in the lining of the intestine. That's where we are trying to digest and absorb the gluten. But rather what happens is that the gluten proteins set up this reaction. And in that reaction, you get damage to the lining of the small intestine. Now the small intestine is lined, the normal small intestine is lined with villi. Villi are like finger-like projections. And they're there really to maximize the amount of working area we have for digestion and absorption. And it's been said that if you could iron out the small intestine completely flat, that it would cover a tennis court. Now, of course, in celiac disease, if you lose all those finger-like projections, you get damage and it ends up being flattened. So you end up with an intestine that instead of looking like a deep pile carpet, it looks more like a tiled floor. Then you end up with a surface area that's substantially smaller, maybe more like a table tennis table top, but a much smaller working surface area. Now, we know that's from work that we've done here, that celiac disease affects a variable amount of the small intestine. In some patients, it's just 1% of the intestine. In others, it could be 60 or 100% of the small intestine. And the consequences can be very variable. Some patients have terrific diarrhea, weight loss. If they're young children, failure to thrive.
I'll take your number and let him know you called.
They may have severe osteoporosis because of lack of vitamin D and calcium. They may have other consequences. They may have grown to a shorter height than they would have achieved other than having celiac disease. It can affect the permanent teeth, and often dental loss is pretty common in patients with celiac disease. But there are other patients who don't seem to get those same symptoms. They get problems like anemia, where they've got low iron or low hemoglobin, especially if they can't respond to oral iron. So their doctor tells them take iron, but they don't respond. Maybe because they can't absorb iron. And again, that could be a clue to celiac disease. The treatment is safe. Going on a gluten-free diet is a safe endeavor. It's not easy because of how pervasive wheat, especially, is in our diet, and there are many hidden ingredients that are made from that can be a problem for somebody with celiac disease. It's certainly not an easy diet, not one that should be followed casually. A precise diagnosis is necessary to justify becoming a gluten-free diet for life. It can be socially restricting. It can make it more expensive. It certainly is more expensive to adhere to a gluten-free diet because you have to source foods in special ways, either by mail order or from specialty suppliers or from manufacturers that take great care to avoid contamination of their food with gluten. So that's an area that to be on a gluten-free diet doesn't just require, let's say, self-teaching, go on the internet, look for information, but really requires a consultation with an expert dietitian, somebody with expertise in celiac disease. I think to summarize, the most important thing is if somebody suspects they have it, is to be tested before it's treated. The second thing is celiac disease is not a trivial disease. It can be associated with substantial complications. And one thing we didn't mention is it had been thought maybe 20, 30 years ago that people who had celiac disease as children could outgrow it. That's not the case. If somebody had a diagnosis as a child, and they almost certainly still have the disease, they should be gluten-free. So this is an area where we've got new data, new information. It's rapidly changing, but it's also one where I would see some hope for the future in terms of finding the people who've got hidden celiac disease, understanding what that means in terms of their health, and giving people the tools who have celiac disease to live better lives, less socially restricted, and be able to live a essentially normal lifestyle with an interesting, varied, and healthy diet. If you have a family history of celiac disease, brother, sister, parent, or child with the disease, I think there's very good evidence that you should be tested for celiac disease. If you've got premature osteoporosis, certainly type 1 diabetes, it certainly should be considered. Patients with unexplained infertility, a whole host of other ways in which celiac disease, you can mimic irritable bowel syndrome, which is obviously much more common than celiac disease. Again, it's a question of once the disease is suspected, a test should be performed before the diet is altered. But the big challenge is getting people to think about the diagnosis.
So again, okay, this is a disorder that's part genetic, okay? It's gluten sensitivity, and gluten is a protein in flour that causes in these individuals an autoimmune response. So what that means then is that your white blood cells turn and attack the lining of your digestive system, okay? What happens in normal individuals is that the gluten is broken down into amino acids and absorbed into the blood. But in people with celiac, what happens is that you end up with incompletely digested protein. And what will happen is that, number one, this protein will make it to the colon, and that can cause problems in the bowel, but you'll see destruction of the lining of the digestive system, okay? The villi will be destroyed. The walls will end up being scarred and inflamed, okay? Symptoms will vary. Children with celiac have diarrhea, steatorrhea, again, that's floating stool because of the fat in it, anemia, abdominal distension, impaired growth, lack of appetite, and fatigue. Typical symptoms in adults include diarrhea, abdominal pain, bloating, anemia, steatorrhea, and osteomalacia. Okay, what is osteomalacia? This is essentially bone malformation. Okay, and it's basically a result of the problem with um, with calcium metabolism and with the production of collagen. Okay, treatment is limited to avoiding gluten. Eliminating this is difficult, but there are diets that are gluten free. Okay, some gluten free products are unappealing and are more expensive. Prognosis is good for clients that stick to the diet. Okay, so when you hear about people going gluten free who don't have celiac disease, it's really not necessary. All right, it is necessary for people with celiac. Tell clients to eat foods that are gluten free, including what? Milk, cheese, rice, corn, eggs, potatoes, fruits, vegetables, fresh meats, and fish, and dried beans. Okay. Basically, you want to avoid wheat. Okay. And I know you might think, okay, well, no wheat flour, no bread. But again, you can have wheat additives, thickeners that are in a lot of other processed foods that you don't realize are there. Okay. Remind clients to read labels on processed products. Gravy mixes, sauces, cold cuts, soups, and other products can have gluten in. Okay, tell clients to read labels and research the non-food components. Okay, as well because they can contain gluten. All right, and this can result again in the disease symptoms showing up. Right. Okay, with bariatric surgery, what we're doing here is trying to reduce the amount of time the nutrients have to get into the blood or into the lymph. Okay. Benefits include reduction in weight, reduction in blood pressure, um, the, uh, the the essentially the reversing of type 2 diabetes mellitus. Okay. Um, dyslipidemia. Okay, and mortality. So in gastric banding or lat band, what they do is they put a device around the stomach. They usually go in through the uh, the navel, right, um, where the umbilicus used to be attached, and then they they put this band or this inflatable. It's almost like a looks a little bit like a lifesaver. Okay, around the stomach, and the idea is to reduce the size of the stomach so that you have to eat smaller meals and you absorb less nutrients. Okay, a gastric bypass is where ingested food skips 95% of the stomach, the duodenum, and a small portion of the jejunum, and um, weight loss is achieved through malabsorption and dumping syndrome and the altering of the hormone ghrelin, which causes hunger. Okay, so what are some problems with this? Post-op complications, anastomostic leaks. Okay, and anastomosis is just a narrowing of an opening, right? And so if they narrow the stomach, the area where they've narrowed it can leak. Okay, internal hernias, GI bleeding, stomal stenosis, and gallstones. Micronutrient deficiencies can be a problem. In a sleeve gastrectomy, what happens is instead of a band, all right, um, a longitudinal portion of the stomach is removed, and that creates a sleeve effect and reduces the hormone ghrelin, which causes hunger. Right, bariatric surgery works best in combo with diet and lifestyle changes. If you just do the surgery and then you don't control your intake, the stomach's going to stretch back out and the weight's going to come back on. And a lot of people end up doing that, cost themselves a lot of money for nothing. Okay. With adjustable gastric band, tell the client that the diet will gradually increase from liquids to puree to soft foods as they take the pressure off the band. Okay, and tell the client importance of chewing the food thoroughly, swallowing it, and taking it in small amounts. Okay. Um, Again, another problem with all of these is dumping syndrome, right? And we know the problem with that is that the acid in the stomach can end up eroding the lining of the small intestine and eventually could carve a hole in it, right? So bottom line, if you want to lose weight the safe way, it's the old-fashioned way, which is reduce the amount of calories you take in and increase your exercise levels. Okay. And then you don't have any of these complications that can come from surgery. Anytime you're opened up and they do something and close you back up, there's a risk, right? There's a risk of infection, there's a risk of complications. And so you want to reduce that risk as much as possible. Okay. All right. So let's take just a quick break. Um, let's take 5 minutes because we don't have a lot of time here. And then we'll do kidney disorders. Okay. So I'll see you guys back here at, let's say, 12:15. Okay. All right. Cool.
I can't hear anything, Mr. Converse.
I'm sorry, guys. I was on mute and I didn't realize it. Okay, so let's go back one. All right. So the idea behind your kidney is that your kidneys are responsible for cleaning your blood of waste products, right? And what are those waste products? Ammonia, urea, anything has nitrogen in it, toxins, okay? Kidney is also responsible for maintaining your body pH, maintaining your blood pressure, maintaining your electrolyte balance, promoting blood production, okay? And maintaining your blood volume. All right. All of that is going to be compromised if your kidneys go down. And there's a number of ways that your kidneys can be damaged. They can be damaged by certain diseases. They can be damaged by trauma. Okay. They can be damaged as a result of conditions that primarily affect other organ systems. Okay. So loss of kidney function is, if you have total loss of kidney function and you don't do anything about it, you have 2 days to live. Okay. Because your blood will build up so many toxins that your cells and your tissues won't be able to maintain function due to things like denaturing of protein and screwing up the pH, and they'll die. Okay. So it's critical, right? If your kidneys totally go down, all right, what we have to do is put you on dialysis just to keep you alive, where we artificially clean your blood by removing waste products through diffusion. And we do that by passing your blood through dialysis tubing, which has tiny pores in it. The waste products diffuse out, and the good stuff in the dialysis fluid diffuses in. And then we return the cleaned blood to you. Okay, there's a couple of ways to do that. There's peritoneal dialysis, and there's something called hemodialysis. Okay. In hemodialysis, we route your blood through a dialysis machine, and you have to go to a clinic to do that. Okay. And we put a shunt in your arm, and we take blood out of one vein, pass it through the machine, through the dialysis tubing, and then put the blood back into your body in another vein. Okay. So it's vein to vein. In peritoneal dialysis, we do something different. We put a port in your abdomen, and then we fill your abdomen with dialysis fluid, and then we remove the toxins by them diffusing into the fluid, and then we drain that fluid off, and then we do another fill and drain, okay, and then you're clean for a couple of days. And so that's a low-tech thing that you can do at home if you have the proper training, okay? So what are some causes of kidney damage? Well, trauma, infections. You can be born with certain types of kidney diseases. Meds can damage the kidney. Chronic diseases include CKD, ESKD, AKI, nephrotic syndrome, and kidney stones. Okay. There's our treatment, right? Hemodialysis or peritoneal dialysis. CAPD is sort of a variation on this, where you walk around with a dialysis bag connected to your port in your abdomen, and it just goes on and on and on all the time. And the advantage of that is you can walk around. Okay. You can do peritoneal or CAPD at home if you're properly trained. And so then you don't have to transport the patient anymore. The cure is a kidney transplant. But the problem with the cure is that you have to find a kidney that is a match, a tissue match for you, or your body will reject it. And that's one of the reasons why most successful kidney transplants come from living related donors, meaning brothers, sisters, parents, first cousins. Okay. That's why you want to be nice to your family, because you may need a kidney from them someday. Okay. You want to monitor weight as per your physician, right? Weight is an indicator of your fluid status. Monitor fluid intake and compliance. Monitor urine output. Monitor constipation. Talk to them about why they have to change their diet. They're going to have to change their intake of calories, their intake of electrolytes, their intake of vitamins. Okay. With CKD, we have different stages, right? They're shown here, from at risk all the way to end stage kidney disease. Leading causes: diabetes mellitus and hypertension. Now, why is that? Well, let's look at diabetes, right? What happens in diabetes if you don't treat it is that sugar builds up in the blood, And then that gets to the kidneys, and the kidneys can't put all that sugar back into the blood because there's too much to put back in. The result is that you put strain on the nephron, okay, and you damage the nephron to the point where it can't work anymore, okay? And there's a few reasons for this. There's physical damage to the nephron because of pressure problems, okay? And then there's damage to the nephron because the tubing in the nephron can't properly move the material where it wants to move it, right? And anytime you overload a tissue, the tissue will just quit on you, okay? Hypertension is bad. Hypertension is associated with diabetes because the extra sugar in the blood causes extra fluid in the blood, which causes more blood volume, which causes more pressure on the glomerulus, which is the first part of the nephron. And when you do that, what happens is that the filtration membrane in the glomerulus, which is basically the tissue barrier between the blood and what's called the filtrate in the nephron, which is eventually going to be your pee, gets stretched out, and you start leaking stuff from your blood into what's going to be your pee that normally wouldn't be there, like proteins and sometimes even red and white blood cells, okay, and other important nutrients. And so basically, those nephrons aren't doing their job anymore. They can't put all that stuff back, okay? And you can tell this with a dipstick test for the urine. You can put a dipstick in the urine and you can pick up whether there's protein there or other components that don't belong, okay? So what do we do about this? We try to control blood sugar and blood pressure. We cut sodium, and that helps take strain off of the kidney. We preserve remaining kidney function, right? Phosphorus and protein intake is going to slow the progression of the disease. We want to limit high phosphorus foods to a serving or less per day. Meat for men, 5 to 6 ounces, for women, 4. Dairy, half a cup. Too little protein is going to result in the breakdown of body protein, and we want to restrict potassium in order to prevent hyperkalemia, right? In practice, since dialysis clinics are seen regularly, topics are addressed and lab values for the condition of the client are constantly assessed, right? So what do we look at? We look at sodium and fluid management. We look at protein and calorie intake, potassium management, phosphorus management, and vitamin D deficiency, okay? And a lot of that gets corrected, not so much at the dietary level, but in the dialysis fluid level, right? The electrolytes, for instance, can be corrected with the composition of the dialysis fluid, okay? Same with the fluid amounts, right? Acute kidney injury is usually reversible kidney function loss, right? The diet depends upon the phase and the cause, right? Protein, calories, fluids, potassium, and sodium are going to be tailored to the problem that the patient has. Potassium and sodium are dependent on urine output, lab values, and whether or not they're on dialysis. Protein intake is based on the patient getting dialysis. Calcium requirements are greater than 2 grams a day if they're on dialysis. In nephrotic syndrome, what we have is damage to the nephrons, okay? So we start spilling protein and other components into the urine that shouldn't be there. Prolonged protein loss leads to protein malnutrition, anemia, and vitamin D deficiency. Diabetes mellitus, again, we're talking type 2. Kidney damage due to meds or chemicals and autoimmune disorders, as well as infection, can be a cause, all right? So what do? We want to minimize edema, replace lost nutrients, and prevent protein malnutrition. So what do? More protein and less sodium, right? So there's soy-based protein. Carbs should provide most of the calories. Limit trans fats and cholesterol. Total fat greater than 30% of the daily diet. And multiple vitamins as supplements to those that are lost in the urine, right? Kidney stones. I have personal experience with these, okay? These are little calcium oxalate crystals that form in individuals that either have hormone problems or have a diet that's high in diuretics. Things like caffeine and alcohol are dietary diuretics. There are also medications that are diuretics. And what happens is these little crystals form in the urinary system that can block things like the ureter draining urine into the bladder. And then you get this horrible pain that radiates through your abdomen and your groin, and you feel like you're being kicked between your legs while being highly constipated. Okay, and that's another example of what we call referred pain, and it is pain bad enough to make you throw up. It's that bad. Okay, stone formation is influenced by the amount of oxalate and calcium you have. Okay, the oxalate combines with the calcium and makes the crystal. All right, and you get oxalates from things like certain green leafy vegetables like spinach and kale. Okay, and you get calcium from a variety of sources, mostly dairy. Right, so what we do prevent this: limit animal protein, sodium, calcium, and foods with oxalates such as spinach, rhubarb, beets, bran flakes, nuts, potato chips, tea, and chocolate. Okay, increase fluid intake to 1.5 to 3 liters, 8 to 12 ounces of water at bedtime. This is one of the best ways to avoid this because the extra water dissolves the stone, but it also dilates the ureter so the stone can clear and get to your bladder. And once the stone's in your bladder, then you're pretty much home free. Limit foods with oxalates in them. Low potassium level can contribute to stones. Avoid high doses of vitamin C, which increase the amount of oxalate. Preventative measures for uric acid stones are to limit foods that are high in purine. Lean meats, organ meats, whole grains, and legumes um, are, again, going to be limited here, right? Because the kidney isn't doing its job, right? It's not dealing with the nitrogen very well. So we have to take the load off the kidney so that it doesn't have to do a lot of nitrogen metabolism, which means lower the protein, okay? Lower the protein because the kidney can't handle it. When do we go back to normal diet? When kidney function's recovered, okay? So this is, you know, this is your body's, you can think of it as your sewage treatment plant, right? And if that stops, where does the sewage go? It goes into your fluids, right? And they get contaminated, and then that kills you, okay? So this is serious stuff, right? Your kidneys take about 200 liters of blood a day, and from that they make about 2 liters of pee, okay? And your kidneys are about the size of a bar of soap. So think about that, right? Two two organs the size of a bar of soap are dealing with all that liquid, okay? And if you've ever seen a dialysis machine, it's about the size of a refrigerator and does the same thing, and it takes longer, right? If you're on dialysis, hemodialysis, you have to go 3 to 4 times a week, and it's 4 to 8 hours each time, depending, right? So you got to be nice to your kidneys, okay? Do not stress them. And in patients that have these conditions, you have to think, what does the kidney do, and how can we take the stress off the kidney? And the big main thing, right, is to cut the nitrogen intake. Okay. And then for the stones, that's the special instance of the oxalates and the calcium. Okay. All right. We're at time. We're done. Okay. Um, like I said, I will have your scores up. Um, I will have your scores up as soon as everybody's taken the exam. Okay. And then we will we can go through the exam and see where the problem areas were. Um, our second exam is coming, and we need to prep for that. Okay, so I'm going to send you guys um, a practice for the second exam. Okay, and then we'll go through that as well. And then also, I think I sent you guys a link to my Friday tutoring from 5 to 7 p.m. by Zoom. If you haven't gotten it, I'll resend it. And if you have questions, just pop in and tell me your school and your course, and I'll help you guys out. Okay, not just with the nutrition course, but with A&P or any other science-related course that you're taking. Okay, and that's my time for you guys. Okay, so anything you got question about, we can go through it, we can talk about it, and we can make it more understandable. Okay, I will post the podcast of this um, soon as it processes. Okay. And before we bump out, does anybody have any particular questions? Are we cool?
Mr. Converse, I missed the first 10 minutes of class. So is that all that you said at the beginning of class?
Yeah, it's going to be on the podcast. Everything's going to be in the podcast, and you can pick that back up.
Okay, all right.
Yeah, yeah. Anybody else? We cool?
Nope. Have a great day.
All right. Thank you.
Thank you.
Mhm. There we go.